All right. Well, while people are still joining, I just put up a few introductory things here. So welcome everybody to the CFAR conference this Friday, and just a few notes and highlights. So today we're going to have Bartlett updates and an introduction to a fatty liver disease study that's going to be going on in the clinic. And then next week, so the 10th of November, next Friday, we're going to have a hybrid session, so both in person and virtual. Hopefully the virtual will work, and that'll be in Rango's 590 with lunch. And we have the guest speaker with us on that day, Dr. Monica Gandhi. We're going to be presenting her some cases, including some of the cases that we've recently discussed in conference, to talk about implementation of long-acting therapeutics in different populations. So please do join us. I'll put this in the chat again later. If you would like to come and have lunch, we would love to have you. You can RSVP. Laura Clark had sent out an email about this earlier in the week, or you can just drop it in the chat to her today. Her chat address is currently CME code. So just chat the CME code individual on this meeting and tell her that you will be joining us for lunch and the meeting next week. On the 17th, we'll have cases, and there's a Thanksgiving break. And then just for everybody to look forward to, in the first week of December, on World AIDS Day, we're going to have Francesco Simonetti and Vivek Hariharan are going to give us an update on non-suppressible viremia in a couple of cases that have been discussed in this forum before, including one from David Block and one from Liz Gillums. So please also make sure to attend that. I'm sure it'll be very interesting. So without further ado, I will turn it over to Sheila and Stephanie, who are going to give us some Bartlett updates.
Good afternoon, everybody. Happy Friday. So the first thing I'm going to start with is the Quality, Safety, and Service Comprehensive Dashboard for the Bartlett practice for the month of September. I know it's always a month behind, but I just want to show all the great work that we're doing here in the clinic. So I'm going to share my screen. I think everybody should be able to.
Yep, looks great.
Okay, good. So so this is for the month of September, and the first category that we're going to go through is our safety here in the clinic. So as you can see, what the targets are, we're doing great in hand hygiene. We're at 99%, and the target is 90%. For patient ID, we have fallen down a little bit. The target is 86%, and that's where the patient, we really need to ask patients their name and their date of birth before we give them any kind of treatment. And I think sometimes, because we've known our patients for so long, that doesn't always happen. And so we have been reminding people in the huddle to always ask patients for their name and their date of birth. So in basket monitoring, I always just give kudos to the nurses and to the providers. We are exceeding in that metric at 96%, with the mark being 90%. For closing encounters in 14 days, again, look at that. We are exceeding the mark at 90%. We're at 91%. For the test follow-up in 14 days, we're very close to that. We need to get to 95%, and we're at 92.99%. Medication review, I can recall in the past, years being here at the clinic, we're getting much better about medication review when patients come into clinic, and we are almost there. We're at 85%, and the mark is 90%. For OBGYN, we are doing a great job with chaperoning 100% of the time. So that's great. One thing to note here on this safety measure is that there were no heroes that were put in the month of September. And that in itself is a little concerning. It's very important when you see something that's a safety issue you know, something that you believe could cause harm to a patient, a workflow that you just don't think is the best here in the clinic, it's always important to put in a hero. So we really do encourage people to put in heroes. There's nothing, it's not going to be punitive. It's a way that we can learn and we can improve our ways of doing things here in the clinic. So I ask that if you see something, please submit a hero, and we try to make things better here in the clinic. I'll stop there a minute and see if anybody has any questions, comments, or concerns.
Hey, Sheila, could you just comment a little bit on, as someone who's never put a hero in? So would you recommend doing that as like, in addition to speaking to someone in the clinic, or instead of, like, I know sometimes these things that trigger institutional records are actually helpful to the clinic in terms of showing when we need more staffing or something like that. So whereas I think, as you said, like, not that I thought anyone would get in trouble, but I tend to think if I just talk to somebody, that's enough, but maybe I should revise that.
I think talking to someone and also putting a hero in, I think both of them would be good to do. So I think it's in addition to.
Great. Anybody else with any questions or?
I'll just add to the hero kind of question. I think that's a similar mentality I try to do here at the pharmacy, is telling my staff, like, we follow just culture, so you're not going to get in trouble, or you're not tattletelling on. It's not the culture of like trying to get somebody in trouble. It's really like, even if it's a near miss of a safety concern you have, like, put it in as a hero, because we can track that and we can make sure that we have the appropriate like review via leadership, and we like talk about it as a group, and we come up with strategies to really make sure that we make up processes when we can to make sure that we address these safety concerns before they actually reach a patient.
You can also sometimes get more resources for something because it's documented. It's not necessarily true these days, but like, it is possible that if someone at a higher level gets involved, you can get more money to fix it, or other resources.
Yeah. Okay. So good questions, good discussion. Thank you. So the next one is our quality metrics. And we are really moving along here. In our breast cancer screening, we went from 59% to 64%. I believe that Abina's hiring into the CMA Maryland PCP role has been a huge help getting people over for same-day mammograms. So that's really good. We're staying steady with the colorectal cancer screening, and Stephanie Thornton and myself are on a work group, and Dr. Jones with Samantha Pitts, where we're really trying to look at all the barriers to our patients either completing Cologuards or colonoscopies, and some progress is being made there. There's a lot of barriers, a lot of challenges, and we're chipping away at them, and just like a hero, you know, we are making some strides, and I think things will improve in that. Our patients need a lot of support to get that done. For controlling hypertension, looky there, we're in the yellow now, we're no longer in the red, so that is great. So please make sure that you're following up with patients who've had blood pressures greater than 140/90. You can always have your nurses involved in that, having people come back for blood pressure checks, sending in their blood pressure readings from home via MyChart, or they can bring them in. Doing blood pressure education with patients. So we just really are very close in that metric, and I think we can get there before year's end. Hemoglobin A1C, the point of care testing here in the clinic has made all the difference in the world. We are meeting that metric. We don't have any kids to give immunizations to, so hence that's blank. Our annual wellness visits for our people that are 12 to 21, you know, it's always a small denominator. And I was talking with Leon, the ACE nurse, the other day, and he reminded me to tell him when we have annual wellness visits coming up with the ACE folks so that we can get them done. Wellness visit, Stephanie's gonna go over that with you in much more detail today. So I am going to let her do that when she speaks. But we are getting better. I know it looks like we fell in that this month, but that's because our denominator got bigger this month, and Stephanie will explain that during her presentation. Any questions there? I want to watch my time. I want to make sure I leave Stephanie time. So,
Hey, Sheila, I'm
Yep.
sorry. Just one comment about the blood pressure. Just want to encourage providers, if you have somebody with an abnormal blood pressure, go ahead and just grab the Omron. And what I do, this is what I do. If it's greater than 140/90, I'll talk to them, do the visit and let them know I'm going to repeat it. And then I put the Omron on and I do it so that it's the average. And I like turn off the lights and I'll like order labs or something like that. And then I repeat it. And I mean, I'm going to say at least 50% of the time, especially for people who are usually well controlled, it's normal. So just one other thing I've incorporated into my practice.
and the CMAs can do that too. Like if you need to get through the visit and say, when I'm done, let's lower the lights, let's do the Omron, stay off your phone, think about a peaceful place, uncross your legs. And you're right, a lot of times it does give a reading of less than 140/90. And that's all it is. People come in here, they rush, they're anxious, and that elevates blood pressure. Yeah, so thank you. That's a very good point. So then the next group of metrics that I want to go over are it just shows the amazing work we do here in clinic. And other clinics, I just want you to know, don't have scores like this. So I always brag on the Bartlett. Like we've been used in quality meetings about patient experience, about how do we get these great scores. So just kudos to everyone. Thank you so much. Overall provider rating 92%. Recommend this provider office 93%. Appointment access 87%. Overall visit rating 88%. Provider communication quality 95%. Staff quality 97%. Telemedicine, if somebody doesn't understand it on their end, they're not going to give us a good score there. Visit wait times, we exceed that at 83%. And then staff worked well together. We usually exceed in that too. And I don't know why that dropped this month. So just thank you, everyone. Great work. Any comments there? All right. Yeah, clapping. Joyce puts clapping. Yes, great job. So then down to our value metrics. Still work to do with the hospital admissions per 1,000 patients, the ED visits per 1,000 patients, and the readmission rate. There's a group of us that are going to meet about working with complex clients and what we can do to, lower these numbers of patients being admitted, going to the hospital and going to the ED. So more work to come on that. Would love anybody's ideas on that, because I really think we can affect that positively as well. And then go ahead.
So I was just wondering, like, and from the quality side, like, is there a review of like reasons for admission and duration of stay and things like that? Like, as some of those things are like good metrics of whether or not, like, it's just sick patients or if it's a potential averted.
No, but that's a
admission.
very good idea. You got to look to see in the detail, right?
Right. Because if someone's in the hospital for 5 days, they probably needed to be there. Whereas if someone is in the hospital for a day and a half.
Yeah,
and
exactly.
I mean, and that's not always true. Like sometimes there's other things that intervene, but just the ways of trying to get it so we can focus more on the people who are going because of lack of access to services we could provide versus those who are going because they're very sick.
Yeah. And who are heavy utilizers that go to the ER, but don't come in here for their appointments, right? That's another thing to be looking at it. And then like, even if you look at the top 5 people and what are we doing for those people, high risk, high support is the way I look at that. What kind of more supports can we put in place? So yeah, all good, all good. You always get into the details. When you get into the details, you really find out what's going on. So
Because
then
it
for
al-
our,
Yeah,
ahead.
and I just feel like it also gives us a chance to not just say like, oh, our patients are hard, but to like actually identify those who we can do better with instead of like, and I'm sure we could make some improvement, but
Yeah, I agree. And then for our transitional care management, again, I just always like to because I don't want the nurses that do this to get down from this. We really do try to get a hold of patients, and I really know that we do try to get people in here at 7 days and 14 days, but sometimes it's really hard to get a hold of our patients. So it's not for lack of effort. So I'm going to stop sharing because Stephanie has a great presentation to give to you now
just one more
on
quick
our
thing.
metric of the month, which is annual wellness visits.
Just one more quick thing. I promise, Stephanie, I'll be super quick, but can we reduce that burden by having like, I guess it would only work for those who are admitted to Hopkins, but like having the follow-up visit scheduled at discharge, because the way that discharge appointments work is like not very direct in terms of like someone gets emailed who calls an access or like, but if one of our patients is on the service, like, and I'm on Polk, I usually try to reach out to schedule the follow-up, but if we had that as a more systematic thing, would that help those nurses who are doing that post-visit follow-up? I guess that's ED and other hospitals too, so maybe not. I'll stop talking.
No, that's a good idea, Eileen. I think that is something that we could make a change in. It makes sense. So yeah, I'm going to try to follow up on that.
Maybe Stephanie, can you speak to that a little bit more? Because I thought that was part of the process, right? Like we get notified when people have an ED visit or a hospitalization, and aren't nurses supposed to sort of reach out and arrange for a follow-up appointment?
Yes.
And
So
like,
yes,
yeah.
the process is when we get the notification for admissions, the patients have to be reached. So reached is the key word, right? We have to actually
That's
get
the
into
word.
contact with them. We have 2 days to reach them by phone, and then those patients have to have a visit within 7 to 14 days. Now, if we can't reach the patient in those 2 days, we do not get credit for the attempt. And then the other nuance is that when we do have the opportunity to reach the patient and we schedule them for an appointment, whether it's with an attending or if their provider has some availability within that time frame, if they do not show up for that appointment, then we don't get credit for that either. And then with
But-
the ED visits, we have 7 days to reach them, but the patient is not required to have a follow-up visit unless it's indicated. So that's more of a nurse judgment.
So, so just a couple of things. One is if we know that they're hospitalized, then there's a direct way to reach the patient and the team because they're in the hospital. So there's a way that nurses could reach out directly to the team. And in fact, teams have been great reaching out to me, which I have really appreciated from the inpatient side so that I can help facilitate a follow-up visit.
So
So
we're
that's
not
one
getting a
thing.
notification until they're discharged.
No, Steph, when somebody's admitted, I think there is when you make yourself a part of the care team, I think there is a button that you can hit for hospital
Yeah.
admission notification.
Even if you're not the PCP. So if you go into the care team and then you add yourself to the care team, there is a button that you can click, a selection you can make to say notify about admission, even if
Yeah.
you're not the PCP.
So
So-
providers are probably getting a notification, but not so much the nurses if they're not in the care team.
So the nurses need to add themselves to the
yeah.
care team and select that. So
Okay.
I'll put that
And
down
then-
for the nurses meeting.
Yeah. So Natasha, I would just check. Yeah. Like if you go into your patient, you, it doesn't always default. Yeah. And I can do like a little sometime, like just a screenshot about care team because I'm familiar with it and I add people sometimes. Yeah, and then sorry to derail stuff, but I thought that was like a really helpful point. And I think just for providers, you could loop in your nurse when you get that notification about setting the patient up with an appointment, either with you or with an acute for a post-hospital discharge follow-up visit.
Yeah. So that will be a great intervention, a great way for us to capture the patient while they're there, but I don't want to confuse that with this actual metric. This metric is based off of a template that's completed when the patient is discharged.
Mhm.
And I think we should bring that up, though. I mean, like, that's even better. Like, that care coordination while they're hospitalized is even better than after they're discharged. So I
agree.
think we should try and revisit that metric. And is there a way that if you're filling out that form that it counts? Because it really should. So.
Okay,
All right, well, take us away, Stephanie.
I'm going to share. Can you guys see my screen?
Yes.
Yes.
Okay, wonderful. All right, so these are our additional Bartlett updates. So Sheila did mention that we have this wonderful GI collaboration, and it's going great. And we had one, I think just last week, and there was a Bartlett provider that was in the office, and I just asked her to sit in, because I think, you guys' insight is always helpful. And in that meeting, we found that there's a discrepancy with the colonoscopy order. So there was a new order rolled out at some point, and it includes some additional screening questions. And apparently, if you have this older order favorited, it didn't manually push through the new one. So she found that she was ordering an older order, and I'll show you guys screenshots of what they both look like. And I did reach back out to leadership, and they said that they knew about this. They reached out to Epic when it rolled out, and unfortunately Epic was not able to change it so that it is automatically updated to the new order if you have the older one favorited. And then I just also wanted to mention that another thing that was discussed in terms of barriers is on their end, sometimes they're receiving incorrect orders for colonoscopy. So they're receiving ambulatory referrals to GI, and she didn't specify that it was the Bartlett doing it, but this is just in general. So I wanted to just mention it in case that could be the case. They're receiving ambulatory referrals to GI as opposed to the Pro 255 order. And so that creates a delay in the chart review process, because then they have to reach out to the provider to determine if you actually want the patient to see a GI specialist, or if you actually want a colonoscopy, or both. And if it's both, then that's fine, but two separate orders have to be placed, one referral and then one Pro 255. And so this is the outdated order. I don't know if you guys have seen this, if you have this favorited. This is the outdated order. And this is the updated order. So as you can see, the patient conditions are different. So in order to change that, unfortunately, like I said, they already reached out to Epic, and it's not something that could be manually done. You just have to, you can search Pro 255. This order will also show up, and you just can add it to your preference list or favorite it, and then that would swap them out. So I thought that was great, because I wouldn't have known that. I don't order these tests for patients. I thought it was great that the provider was here and she caught that, and she noticed, we were talking about the orders, and she said, oh, my order doesn't look like that. When I order the EGD, this is what it looks like, but not when I order colonoscopy. So that was a great catch. So I just wanted to share that with you guys as well. And so to talk about wellness visits again, this is going to be our metric of the month. As we approach the end of the year, we would like to really focus on wellness visits for the end of the year push. And so I just want to define the metric again. We have a target of 80%, and our patients 65 or older as of December of this year who've had a PCP appointment within the calendar year in the last 3 years, they are the patients that are falling into our denominator. And to be numerator compliant, there needs to be a visit encounter with any of the appropriate AWV CPT codes, and I have those here on the slide. And it has to be documented in either office visit or televisit. And Abina has been great. She's been great with helping both the patients and the providers in completion of wellness exams. And as Sheila mentioned, although our denominator increased and caused our target to decrease, we completed 49 additional patient wellness visits in the month of September. So I thought that was amazing. And so if you guys have any questions about the HRA or the smart set, or, there was some confusions about the billing codes. Apparently with Epic rollouts and upgrades, things have changed and things are looking different. So Abina has been great in helping providers kind of navigate that. And so we were able to complete 49 more in September, and I'm looking for us to have more completed in October. And just to go over just identification, just as a reminder, so the AWVs are not limited to just our Medicare patients. It's all patients over the age of 65. And there are various ways to identify the care gap. We have our storyboard where it'll come up in the care gaps. We have in your schedule, you can add a column, will let you know what's due. And I have a little snippet of that here. And you can add additional care gaps as well, your mammograms, your colon cancer screenings, et cetera. And then they recently reactivated the best practice advisory. So I don't know if you guys have seen this already, but now when the HRA has been completed within 30 days, you will have the best practice advisory that will show up for you, and it's actionable. So you can either open the express lane from there, or if you're not doing a wellness visit that day, you don't have to open it. And so I thought that was great and very helpful. And so patients who have other insurances, so your MedAdvantage plan, your Priority Partners, USFHP, some of our EHP patients, they can have their wellness visits done at any time of the year. So January 2024, if they come in to see you, they can have it done. But with the Medicare patients, they would have to be specific. So if you were to have done it last October, it would need to be done again in October. And so I just want to go over a little more our performance. So in August, we had 110 patients completed, and then we had a denominator of 167. So our metric value was 65.87. And again, the target is 80%. And then in September, we had 159 patients completed, but our denominator was 252 because again, it's that rolling month. So more patients dropped into the denominator, about 84 more patients. And then as I took a deeper dive into that, I pulled the reports and kind of see where we went wrong and what opportunities were missed and why. I found that 98 of those patients in that denominator have been past due since January. So that means they haven't had one in 2022 or maybe 2021. And I just looked a little bit further because I just thought, how many times have the patients been here? And for whatever reason, we were not able to get the wellness visits done. So I created this quick little pie chart just so that you guys can see. So 10% of those patients haven't had any PCP visits, and I'm going to follow up with those patients myself and make sure we get them in, if not this year, by January. 30% had at least one visit, and I only looked at PCP visits. I didn't add in any acute visits or anything like that, just visits with primary care. And then we had 52% of those patients who had 2 to 3 visits, and then 8% who had 4 more visits. So with that thinking, we're trying to figure out a way to mitigate that for next year, because again, Abina came on, I think in August, September, and she's been great in helping us get more done, but there's kind of no way for us to catch up at this point. So our current initiatives, we've been talking about the fact that here at the Bartlett, we don't have any other visit type other than follow-up. And if patients are going to be, getting primary care here, they really should be having annual exams. So we've been talking about rolling out a new visit template, which will be annual exam for January, so that when Abina and I are looking at reports and calling patients to be scheduled, if they're due for these wellness visits, we can have them come in as an annual. And that way everybody will be on the same page. We all know that this patient is coming in and they need their annual visit done, in addition to their usual follow-up. And so first of the year visits will be scheduled as annuals for those patients due. And we talked about the dynamics of our clinic. Our clinic, we provide care for patients for primary care or just HIV continuity. So we didn't want central scheduling to get involved with scheduling those annual visits because they don't know all the nuances of our clinic. So this type of scheduling will only be done internally. So that means, nurses could be looking at care gaps and seeing when patients are due for annuals, Abina, myself, and of course, as provider, if you have a patient that's here for a follow-up and they are due for their annual wellness visits, when you send them to check out, you can ask for an actual annual wellness visit or an annual visit to be scheduled. It won't say annual wellness, it'll just say annual. So the goal for next year is for Abina and I to reach out to those patients with missed opportunities or overdue opportunities and have them scheduled into this annual template. And like I said, you guys can also ask in the checkout notes for an annual visit to be scheduled. And then, for resources, we still have the quick guides in the exam rooms. And if you find an exam room that doesn't have one, or you have some questions about it, Abina is a great resource. I'm here as a resource. If I don't have the answers, I will find it and get back to you. And we will love your feedback. So I created a quick survey. I'm going to put it in the chat, but these slides will be shared as well, because we want to know what you think about it. how we can improve the process. We want to know how many wellness visits you think you can realistically complete in the clinic session. How much time does it take for you? So this is a little survey. I'll put it in the chat, and I'm also open to feedback here now if we have the time.
Well, thank you so much, Stephanie, for that really nice presentation, and that colonoscopy pearl is super helpful, right? Because I think, we don't know what we don't know, and that'll be super helpful for many people. So thank you so much, and for all the work you guys are doing to get us to do these things. And it turns out to be easier than I thought it was. I'll speak from personal experience in terms of it felt like more of a burden than it turned out to be. So I have been able to work it into my workflow better.
Many of these questions you
For
guys
sure.
are already answering anyway.
Right.
You just
We're
have to-
already taking good care of our patients. You just
Yeah.
have to document it in a different way. That's all.
Yes, exactly.
We just gotta show it, right?
Yeah. And that's exactly what we all love, documentation. But
Great,
anyway,
great presentation, Stephanie.
Yes,
Thank you
thank
for all
you.
that you do.
and those slides will be shared. But if there aren't any burning questions, I would want to turn it over to our guest speaker, Dr. Woreta. I'll just also mention very quickly before we move on, anyone who wants to come to the in-person CFAR meeting next Friday, November 10th, with Monica Gandhi in Rango's 590, you can RSVP to the CME code on this call here, and we'll order you lunch. So Dr. Woreta, welcome. She's here to tell us about a study that's going to be available in the clinic, and I will turn it over to you. I don't know if you have slides that you wanted to share, but you can go ahead.
Thank you so much, Dr. Scully. Appreciate it. Thanks everyone for letting me to come. So for those of you who I haven't met, my name is Tinsai Woreta, and I'm a transplant hepatologist. I've been on full-time faculty since 2016, and my clinical research is mainly working with the NASH Clinical Research Network, and I'm going to tell you about the newly started HIV NASH Clinical Research Network, which is, and we have several studies. I just wanted to start with asking how many people were aware that we're a clinical center for the HIV NASH Clinical Research Network? Anybody? Okay, all right. I'm gonna tell you all about that. Can everybody see my screen okay?
Yes, that looks perfect.
Okay.
Thank you.
And so I'm going to give you a little bit of background about the creation of the HIV NASH CRN, because I do feel like it was really an important breakthrough. So the NASH CRN, so the NASH Clinical Research Network, this has actually been a 20-year ongoing research network funded by the NIDDK. And the Data Coordinating Center is actually across the street at the School of Public Health. And Dr. Jim Tanasha is the biostatistician who's the head of this Data Coordinating Center. And this work has really resulted in lots of landmark studies in the field of non-alcoholic fatty liver disease. People with HIV were systematically excluded from the NASH CRN because they were thought to be distinct from NASH in the general population due to ongoing HIV infection, the impact of antiretroviral therapy, the use of medications, as well as coexisting infections. So there were pretty big knowledge gaps in our understanding of non-alcoholic fatty liver in persons living with HIV. So this led to the creation of the HIV NASH Clinical Research Network in 2020. And thanks to Dr. Mark Solkowski, we're lucky to be one of the 8 clinical centers around the country who are a site for the HIV NASH Clinical Research Network. And this is funded by an R01 grant by the NIDDK. And as I mentioned, it's 8 clinical centers across the country, and it is multidisciplinary, which includes ID physicians as well as hepatologists. And the funding it started in 2020 when we began our studies, and I'll go through each studies. And we really actually, a lot of patients with living with HIV have been referred for our studies. So we appreciate those who have referred patients for this, because this is important to better understand this important growing complication that we see in patients. I just wanted to give a quick caveat that some of you may have known that the terminology has changed, where the American Association for Study of Liver Disease is no longer recommended the use of the term NAFLD because it was thought to be stigmatizing, and the new term is metabolic dysfunction associated liver disease. I stuck to NAFLD for this presentation just because MASLD, the new terminology, is actually a clinical diagnosis, whereas this our studies focus on diagnosis based on either histology or non-invasive FibroScan measurements. And so we don't have the data for the MASH yet, but for the future, that's going to be something that we'll be incorporating. So I mentioned we have 8 clinical centers. The head PI is Dr. Naga Chalasani, who's one of the world-renowned experts in fatty liver disease, who's at Indiana University. Dr. Mark Solkowski is the PI here at Johns Hopkins, and he appointed me as the local primary PI. And then Dr. Rohit Lumba is another world-renowned expert in fatty liver disease, who's at University of California, San Diego. The other centers include UCSF, Duke University, Virginia Commonwealth University, UT Houston, and University of Alabama. We also have very experienced pathologists, many of whom have been working with the NASH CRN for the past 20 years, Dr. David Kleiner and his colleagues, as well as the Data Coordinating Center is also involved with this study. And again, it's at the School of Public Health led by Dr. Tanasha. Just a brief background. So NAFLD has become the most common cause of liver disease worldwide, and it's the second leading cause for liver transplantation in the US. And with the availability of highly effective antiretroviral therapy, chronic liver disease has really become a leading cause of morbidity and mortality in persons living with HIV. And NAFLD is actually projected to become the leading cause of liver disease in the aging HIV population. We already had some studies that show higher prevalence of NAFLD in HIV, but the problem was that there's been various modalities used for defining NAFLD. And so it does vary quite a lot. And in addition, a lot of studies are limited to single centers with small numbers of patients and included patients with concurrent viral hepatitis. So that's why this multi-center study is an important step in really finding out the true prevalence. There's also a few studies that indicate the prevalence of NASH, so the subset of fatty liver disease where you have active inflammation with hepatocellular injury that can cause fibrosis. That's actually been shown to be higher in persons living with HIV in terms of having fibrosis and advanced fibrosis. So really to really define the prevalence and understand the disease, we really need a multi-ethnic, multi-centric cohort, which we now have thanks to this network. And we're looking at really key questions. The role of metabolic syndrome components such as obesity, insulin resistance in persons living with HIV specifically, the impact of HIV infection and the use of ART on the risk of fatty liver disease, the effect of light to moderate alcohol consumption and whether that's safe in persons living with HIV, effects of coffee consumption, which has been shown to be protective in the general population. What are the genetic variants that modulate risk and severity of NAFLD in persons living with HIV, and the role of the gut microbiome, differences by race and ethnicity, which we know exist in the general population of patients with NAFLD, characterizing the liver histology to see any differences between non-HIV infected patients, and then the reliability of the use of non-invasive methods, which we're using increasingly, as opposed to using invasive liver biopsy as the gold standard, and as well as understanding the natural history, whether there's increased risk of fibrosis progression, and then finally therapeutics. So we have 4 studies that correlate with the 4 specific aims of the studies. Pretty simple. The first aim, we're assessing the prevalence of hepatic steatosis in all comers with HIV. And so that's the first, it's a cross-sectional assessing the prevalence in all comers, including people who drink alcohol. The second aim is focused on following patients with NAFLD longitudinally over time. So it's a prospective observational study. The third aim is mainly focusing on liver pathology and characterizing that and assessing the difference compared to people with just NAFLD without HIV. And then finally, we actually have a therapeutic trial assessing the safety and efficacy of saroglitazar, which is a novel PPAR alpha gamma agonist. So it's exciting to be able to offer. We know NASH therapeutics, there's actually no FDA approved medication for the treatment of NAFLD, even in the general population. So this is exciting to be able to have a therapeutic trial. So for the cross-sectional first aim, this is called HNC 001 protocol, just looking at prevalence of hepatic steatosis in all comers. Basically, we're trying to recruit 1,250 patients among all 8 centers. We will include people who drink alcohol, and will use validated questionnaires, namely audit, to determine the prevalence of alcohol-related liver disease. We also have questionnaires to, for example, on the consumption of sugar-sweetened beverages that we collect on patients. And then we're collecting detailed information about demographics, the HIV disease, the use of ART, and environmental risk factors. The inclusion criteria are pretty simple. It's basically any adult patient with well-controlled HIV. So they have to be above the age of 18 and have HIV suppression on ART for greater than 6 months. We are excluding anybody with liver disease from other forms that's not NAFLD. Like, so for example, patients with chronic hepatitis B, which is defined as a positive hepatitis B surface antigen. They can have had a history of hepatitis C, but they can't have had positive RNA within 3 years prior to enrollment. So if it's been more than 3 years, they actually are eligible. And then if they are on medications that are associated with fatty liver, they're excluded. Again, this is the first one, is cross-sectional. You can refer any patient with well-controlled HIV for enrollment in the study. And it takes about 2 hours for the initial study visit. There is compensation with the $50 Visa card that's provided for patients for their time. And basically, they'll have standard of care labs drawn. We'll get the detailed clinical information that I've listed here. And then every patient also has a fiber scan performed with measurement of the liver stiffness measurement, as well as the controlled attenuation parameter. Patients can also consent for biospecimen banking, which includes plasma, serum, DNA, peripheral blood mononuclear cell, as well as stool samples. So, but it's optional, and there's an additional consent for the biospecimen banking. We do get detailed questionnaires. I had mentioned audit, the beverage intake questionnaires also about physical activity, sleep quality, as well as food security. And the primary outcome we're looking for this first aim is just the prevalence of NAFLD in all comers with well-controlled HIV. And then secondarily, we're looking at prevalence of alcohol-related steatosis, and also the presence of clinically significant fibrosis, which we define as a liver stiffness measurement greater than or equal to 8 kilopascals. All right, any questions about the cross-sectional, the first aim? Okay, so we've actually done pretty well. We're sort of the second highest enrolling from all the 8 sites, and we've enrolled 141 patients. So again, we really appreciate referring your patients. So I'm going to move on to the protocol 2. So this is HNC 002. So this is looking at patients with persons living with HIV with NAFLD, and that can be defined based on histology, which many people won't have if they haven't had a biopsy, or the presence of hepatic steatosis, either by imaging, ultrasound, or cross-sectional study, or CAP score greater than 263 decibels per meter, and the presence of median liver stiffness above or equal to 8 kilopascals. And so we're hoping to enroll 400 patients over the next several years. We do need help with this study because so far we've only enrolled 3 patients, and we need more referrals of people with actual NAFLD. We are going to be testing non-invasive assessments of advanced fibrosis to see if they're as accurate as they are in the general population. And then we'll look at whether persons living with HIV have greater progression of fibrosis over time compared to general NAFLD patients. And we have the NASH CRN data for the patients to look at primary NAFLD without HIV. And I mentioned we have this pretty robust biobank that we're establishing, collecting even genomic DNA, plasma, serum, peripheral blood mononuclear cells, as well as stool for microbiome analysis. So for this study, it's the same inclusion criteria as AIM-1, except we have additional criteria that they have to have either biopsy-proven NAFLD, or, as I mentioned, FibroScan liver stiffness measurement 8 or higher to be eligible for inclusion. All right, and we are going to follow the patients basically yearly, so at 48-week intervals, and we'll get interim medical history, all the clinical information that we need. They'll have yearly fasting labs, which are pretty much standard of care labs, and then biospecimen banking, as well as questionnaires that will be given annually as well to assess any changes in alcohol, diet, physical activity, sleep, food and insecurity, and quality of life, as well as a yearly fiber scan too. So we'll get longitudinal data about fibrosis progression. And I mentioned we'll look at non-invasive assessments and their diagnostic accuracy. We're going to look at fibrosis progression over time. So the incidence of fibrosis progression, which we defined as greater than 20% increase in liver stiffness measurements. Okay, any questions about protocol 2? So we definitely need help with this study. So please please contact us if you have any patients who have fatty liver and HIV who you think would be willing to participate.
Can you just comment briefly on the best way to contact you in case anyone is?
I have the last slide where I have my email.
Perfect.
Also, Quintara Williams is the research study coordinator for the study, and I have her email too, but please feel free to send me an email. Excellent. So thank you. So the aim 3 is mainly based on liver histology. So for patients who have liver histology, they're going to be collecting these and assessing histological similarities and differences between primary NAFLD versus NAFLD in persons living with HIV. And so we have experienced pathologists as part of the network who are leading this analysis. And then finally, we have this therapeutic trial, and we're going to be studying saroglitazar, which I mentioned is a novel PPAR alpha gamma agonist. Looks pretty promising for the treatment of NASH in phase 2 clinical trials. It's already currently approved in India for the treatment of dyslipidemia in diabetic patients. And the phase 2 studies in NASH look pretty promising. So we're going to be looking at saroglitazar at a dose of 4 milligrams daily for 24 weeks compared to placebo. The good news is that we've changed the inclusion criteria, so patients actually don't need liver biopsy, which has been a major barrier to enrollment in therapeutic trials for NASH, because oftentimes patients don't want an invasive procedure such as liver biopsy. So we're going to randomize 160 individuals to receive saroglitazar versus placebo for 24 weeks. The primary outcome we're looking for is hepatic fat content using the gold standard of MRI PDFF. And so it's an MR-based test. No liver biopsy is required. And we're going to be looking at that change from baseline in hepatic fat content to week 24 or end of treatment. Okay, so I should mention that to be inclusion criteria for that is that they have to have 10% fat based on the MRI PDFF at baseline to be eligible. All right, so our current status, we've enrolled 141 patients in protocol 1, which is wonderful. We do need to increase our enrollment in protocol 2, as I mentioned, because we only have 3 patients enrolled, and we are awaiting final approval for the protocol 4 because we did put in that amendment to change the inclusion criteria that we no longer require liver biopsy. So then once that's approved, patients will have option for a therapeutic trial. And so this is just showing our performance compared to the other clinical sites. As I mentioned, we're the #2 recruiting site for protocol 1, which is great. You can see we have a high number of patients who are actually willing to provide serum and plasma and DNA for biobanking, which is excellent, up to 90%, and about half are willing to provide stool sample for microbiome analysis. So total across all clinical sites, 8 clinical sites, we have 845 patients enrolled, which is great because our goal is 1,250 over the next year. For protocol 2, we started recruiting. It's actually been about a year and a half. We did initially, there was a requirement for a liver biopsy, which the PIs realized was a big barrier for enrollment. So that's why we changed the criteria. They do not require liver biopsy for protocol 2. They can be enrolled just based on FibroScan if it meets that threshold of 8. So again, any patients who you think are eligible, please refer. This is just some of the publications and abstracts that have resulted from this network, which again has been ongoing for the last 3 years. So comparing the liver histology, looking at non-invasive scoring systems, looking at genetic risk factors and the risk of clinically significant fibrosis, comparison of differences by race and ethnicity in terms of the risk of fatty liver disease and the presence of clinically significant and advanced fibrosis. There's a recent study that we did looking at food insecurity data from this cohort that's been submitted for publication. So lots of good studies that are coming out. And moving on, I did want to briefly show you the results, and then I hope I have a few minutes for questions. But so this is the summary of this is for protocol 001. We did have 300 patients included from another cohort of persons living with HIV from Indiana University that had the same pretty similar inclusion criteria. So you can see the prevalence of steatotic liver disease in this cohort was 50%. So this is a pretty high prevalence. Over half of patients had a CAP score greater or equal to 263 decibels per meter. If we excluded patients with significant alcohol consumption, it was still 50% of patients who met criteria for NAFLD. And then the presence of clinically significant fibrosis was also pretty high at about 15%. So 15% of patients in this cohort had liver stiffness measurement of 8 or higher. So this is really showing that this is a real problem among persons living with HIV fatty liver disease. The rate of heavy drinking defined by an audit score 8 or higher was about 8.5%. So Dr. Slokowski and I looked at it. We led an analysis to look at the impact of race and ethnicity on the risk of having fatty liver disease and clinically significant fibrosis. So I wanted to briefly show you the data for that. So you can see these are the number of participants broken down by race and ethnicity. So you can see we actually had close to 50% of patients in the cohort who were Black patients, which is good representation that we usually don't see in clinical trials. Hispanic patients comprised 22% of the study cohort as well, which was a good number. And this really closely matches the overall prevalence in the U.S. population of persons living with HIV. So it is a multi-ethnic cohort that's representative of the general population. When we looked at the prevalence of non-alcoholic fatty liver disease, as well as clinically significant fibrosis, what we found is that Hispanic patients had the highest prevalence of NAFLD at 65%, and followed by white patients at 56%, and African Americans or Black patients had the lowest prevalence at 43%. And in the general population, we actually find that Hispanic patients are disproportionately affected by NAFLD and NASH. And so when we looked at clinically significant fibrosis, white patients had the highest prevalence at 22%, followed by Hispanic patients at 14.6%, and African American or Black patients had the lowest prevalence at 10.7%. So that is similar to what we see in the general population. We did regression analysis controlling for various factors that are associated with fibrosis, and even with the regression analysis controlling for these other factors that are associated with fibrosis, we found that Black patients had approximately 60% lower odds of having NAFLD and clinically significant fibrosis compared to white patients, even after adjusting for metabolic risk factors. Hispanic patients actually did not have a higher risk after adjusting for metabolic risk factors. For future direction, we really want to explore the underlying factors that are associated with these differences. So genetic analysis, including PNPLA3 genotyping, is currently being performed. We know polymorphisms in PNPLA3 gene have been shown to be associated with the differences we see in primary NAFLD in the general population. So we'll be performing this in our cohort of persons living with HIV. And we're also planning to do stool microbiome analysis in the subset of patients who provided stool samples. And then we're going to be looking at longitudinal changes to see if there are certain racial ethnic groups who are at higher risk of fibrosis progression and developing liver-related complications. So to Dr. Skelty's question, this is, please feel free to email me. This is my email address, tworeta1@jhmi.edu. If you have any patient with HIV, with well-controlled or HIV and fatty liver disease who may be eligible for Protocol 2. The research coordinator for this study is Quintara Williams, or Quinn, and this is her email below, so you can contact one or both of us. And just have,
And do you also have information at the desk on the way out of the clinic?
yes, we did have
Perfect. So-
flyers that is at the desk, exactly.
So we
I'll
can
make
also
sure
tell
that we
patients
stopped
to-
with that. Yeah, exactly. Yeah, we have gotten some patients when checking out because while they're there to try to capture them, I know Juhi Moon has helped us a lot with that. So I'll make sure that the flyers are still stocked up there. So
The other option would be for patients to call the CFAR hotline, which is also posted at the desk and in all of the exam rooms. And they could get this information through that as well.
wonderful. Okay, I'll remind our coordinators of that. Thank you.
Well, thank you so much for coming to share all of this. It's, you know, a growing problem clearly, and we need to have some better pathways forward for how to manage this for patients. So thank you for doing this important work. And anybody has any questions, please feel free to unmute. Otherwise, hopefully we'll all be thinking about these studies as we see our patients and send them your way.
Thank you so much, Dr. Scully, and everyone for your attention. Really appreciate it.
All right, well, not hearing anyone, I'll just say everyone have a wonderful weekend, and we'll see you next week. Bye.
Thank you.